welcome to another one of our education sessions for our members. This is one of the benefits of being a member, where you come to these sessions, all of which are requested by you, by the way, and you get the opportunity to hear and to listen, but also take part with me and with the speakers and whoever. So I'm Chris Carrigan. I'm the data advisor for Use My Data, and I'm part of the really small Use My Data Secretariat, which is, as you may know, Alison, Elizabeth, and myself. These sessions are for our members, but we cover a whole range of topics, and we always record them. So after we've recorded them, we make them available for others to watch. So even if they can't attend, they can watch. They won't last any more than an hour. We start with a short presentation of sort of 15, 20 minutes on a particular topic to leave as much time as possible for you to ask your own questions, which you can now do through the chat function, and you may be able to raise your hand as well. This is the first time we've used the webinar function rather than the meeting function, so I'll see how this goes and see which one we use for the next one. So if you've got any questions, put them in the chat or use the raise hand function, and we'll pick those up and answer them either as we go through Elizabeth's talk or probably in the main session after Elizabeth's spoken. So today's session has been requested by several members, actually. It's on the subject of social care data. We've done a fair amount of work and sessions on things like primary care data, to a degree, primary care data, and certainly hospital data, secondary care data, but not really done much at all around social care data. So I'm really pleased that Elizabeth's here today to talk about her work using social care data in Scotland, to give us a better understanding of what's out there, how it might be used, some of the challenges, some of the opportunities. And of course, with all our education sessions, the main point is for you to be able to ask your questions, make suggestions, and discuss the topic between ourselves, really. So that's all I really wanted to say. I'm going to hand over to Elizabeth now to introduce herself and then get us cracking with her introduction. Elizabeth.
Super, thank you, Chris. I'll just share my screen so you can see my slides. I'm sorry, I can't see we can't see all your faces. So can you see those slides okay?
Yep.
They look fine. Okay, so my name is Elizabeth Lemmon. I am a lecturer in health economics at the University of Edinburgh. I'm also an associate member of Use My Data, and I run an online network and blog platform for early career researchers using Scottish administrative data. I have been working with administrative or routine data for almost 10 years now, which I can't quite believe because I feel like it was just yesterday that I started. And I've mainly been working with hospitalizations records. Laterally, I've worked a lot with cancer registration data, but I'm also one of few researchers in Scotland who has used social care data. And that's what I'm going to talk about today, as Chris said. I just want to say a couple of things before I start. I'm very sorry that I sound a bit blocked up. I've had a cold for about a week now, and it's not shifting, so I sound a bit but I'm sure hopefully I won't sniff too much. And then also I'm going to be focusing the talk on Scotland. I will say a brief bit about the sort of social care data landscape in England, but it was just to sort of set out at the beginning that in the interest of time and my expertise, I will be focusing on Scottish data. Okie doke. And I'm not able to click through. There we go, I'll do it with my mouse. So we all know somebody who requires care either from an unpaid caregiver or through formal social care services because of a health condition or simply because of older age. This is a beautiful picture of my late grandmother, Elizabeth Hodson, who inspired much of my research. And I love this photograph of her with her telecare alarm on. She received social care services for a number of years before she passed away in 2019. So we all know somebody who needs social care or long-term care, either from formal caregivers or from unpaid caregivers. And we don't have to look very far to see headlines about our social care system being in turmoil. This is because of a number of factors, including the fact that we have an aging population. There are a number of, we see a lot about funding cuts to social care, and also workforce issues within the care system. So it's safe to say that our social care system within each of the constituent nations in the UK is in a bit of a crisis. And really, it's been recognised that it's in urgent need of transformative intervention if it's to avoid collapse. So that all sounds a bit doom and gloom, and I'm trying to be optimistic here. And I think that there is really an opportunity for the unique social care data that we collect in Scotland to help to try and solve some of the problems within our social care system. And that's what the sort of basis of this talk is going to be on. The current social care data landscape in the UK has changed quite significantly over recent years. And as Chris mentioned at the beginning, you guys have had a lot of sessions maybe on primary care data, on hospitalizations data, because we have such a long history of using that type of secondary data in research. But we cannot say the same for social care data. It hasn't happened, and that's partly due to the way that social care data is collected. But this is changing, and you may or may not be aware of some of these changes within England. So I've just highlighted here a couple of policy papers and guidance documents that have come out in very recently about how we better use data within health, but also focusing more on social care to improve the lives of people in the UK. And the situation is very similar in Scotland. Our policy documents seem to just have some nicer colours and graphics on them. But the message is generally, it's the same. It's about this data-driven approach to improving care for people living in the country. And again, there has been this shift towards focusing more on how social care data can help here. And I think that this, the way that the shift has been towards social care has really reflects as well the way that services are provided. And there's been an increasing recognition in recent years that health and social care are inextricably linked. And there is possibly, a lot that we could do within the social care system that would impact on the healthcare system in potentially a very positive way to reduce pressure on healthcare services. And a lot of our policy changes in recent years have been focused much more on formally integrating health and social care services better. And this is reflected in the way that the data landscape is changing in terms of integrating health and social care data systems. Scotland is slightly further ahead than the rest of the UK in terms of its collection of social care data. But that is definitely changing for the better. And yeah, there's a lot of changes in England about better collecting social care data across the country. But in Scotland, we collect data on people receiving social care at home. And I should have said this at the beginning, actually, that I'm mainly focusing on talking about adult social care here. So this is either care that's provided in a person's home or in a care home. So care that's provided at home tends to be formal personal care services, so things like help with washing and dressing, but it can also include like telecare services, like for example that telecare alarm that my grandmother was wearing in that photo at the beginning. That's all captured within this social care data. It's collected at an individual level and it's collected at a national level, so it covers the whole population in Scotland, so much like our healthcare data sets do. In Scotland, we have a unique identifier. Every individual has a unique identifier called a community health index number. And this allows us to link individuals' healthcare records. So it can link your inpatient admissions in hospital to your prescriptions dispensed in the community, in theory to your primary care records, but that's still under sort of development at the moment in Scotland. But it's also increasingly being used within social care so that we can link social care data sets to healthcare data sets, which, as I've said, because of the way that we're trying to integrate health and social care and that we know that there's such an overlap between the two, this is potentially very helpful for research. The Scottish Government historically collected this data, and I should say maybe collated this data from each of the 32 local authorities in Scotland, because social care is a devolved power to the local authorities. So they would basically individually collect this information on social care services and return it to the Scottish Government. So the Scottish Government had a national overview of social care services, adult social care services that are being delivered in Scotland. And this was called the Social Care Survey. So that was sort of collected between around about 2010-11 up until about 2016-17, when Public Health Scotland, which is a unique NHS board in Scotland, took over this the collation of this data from the individual local authorities in Scotland, and they rebranded it from the Social Care Survey and called it Source. They made a number of changes to this data set, to the collection, which I'll talk about, very positive changes, and I'll mention a bit more about them. So that's the kind of history of collecting this social care data in Scotland. As I mentioned at the beginning, I'm one of only, I think, maybe 3 researchers who have used the historic Scottish Government social care survey data in research. And I thought I'd just pick out a couple of things that I did during my PhD using this data. So this is a figure basically from this paper, which was looking at comparing the proportion of people receiving free personal care in Scotland to the proportion of people receiving disability benefits. And I was basically trying to understand if those things are correlate very highly, and if we would expect that in places where the disability rates are very high according to disability benefits claims, this would correspond to a high provision of free personal care. And actually found that this potentially wasn't the case, and there was a lot of differences across the country. Another piece of work that I did, and this was published in 2022, was looking at how unpaid caregivers influence older people's use of personal care services. So really thinking about the interaction between unpaid care and paid care. And I've just highlighted here that this was actually around about the time that I came across the organisation Use My Data, and I thought, okay, although I'm not using healthcare data or NHS collected data, the Use My Data citation is definitely worth putting in here. So I sort of amended it to say that this data is being collected by the Scottish Government as part of their care and support. So the point that I want to make here is that, you know, in the way that healthcare data is used in research, and that, you know, we acknowledge it in publications, I think we should be doing exactly the same thing with social care data. But I came across a number of obstacles when I was using this data in my PhD. So again, just to say, this is the Scottish Government version of the social care survey. So the first thing was the data was collected at a snapshot in time every year. So it was an annual census of everybody receiving adult social care services during a census week. So this made it very difficult to know anything about what happened to the individual in between times. If they were in one year and then the next year, you know, you didn't know what had happened to their care package sort of in between. So you'd have to kind of make a lot of assumptions depending on your research question, but that caused a bit of difficulty. The second thing was I used the social care survey in isolation, so it wasn't linked to healthcare data, which obviously would have been very helpful to try and understand that interaction between health and social care. This was not because it wasn't possible to do this, it was to do with the time that it took to access the data. So I basically applied for the data during my PhD, and I got to, I think, about 4 months before I completed my PhD, and that was when the data was ready for me to use. So I wasn't able to do it. So I ended up just using the social care survey in isolation. The main obstacle, though, was that there was a lot of missing information in this data set, and there was a huge variation in terms of how much missing information there was across the country. So one local authority might have been very good at filling in a particular data item, and another was very bad. And as a researcher, it's very difficult to understand the sort of bias that might introduce to your research. So it kind of undermined a lot of the work that I was doing, because it was very difficult. You know, I'd had to make a lot of assumptions about how selective the kind of cohort was that I was working with. So what are the solutions that have been provided by Public Health Scotland in now that they've taken over and collect this source data set, which is essentially the same, but they've made a number of improvements. So one of the things that they have done is they've changed the collection of this data to be quarterly. So instead of just being collected for one census week, it's collected 4 times throughout the year. And there's actually, some of the information is actually collected for the whole year. So it'll be much easier to track social care clients over time. And it is linked routinely to healthcare data. So Public Health Scotland are continuously linking the quarterly collections to all of the routine healthcare data sets that they hold, which are mainly secondary care, hospitalizations records, and so on. But basically, the Community Health Index number is now collected as part of the source collection, so that we can link it back to any other data set that has the Community Health Index number. And they made a number of changes to the collection of specific data items and said to local authorities, this item is now mandatory that you return this to us. So that really gets rid of a lot of the issues around missing information, because it makes it much more sort of uniform in how that data is collected. So that's a massive improvement. But nobody so far, since Public Health Scotland took over the collection of the source data set, no researchers have accessed this data set. Public Health Scotland do use it on their own, within their own research teams to sort of inform the delivery of services, but no academic researcher has accessed this data. It's possible to do it, and I've been having conversations with Public Health Scotland and with the coordinators within the Electronic Data Innovation Intelligence Service within Scotland, where you access these data sets, and we've sort of established that it's absolutely possible to do so. So it's a bit unclear why. I think it's because nobody really knows about it that it's not being used. But this would be accessed in the same way that we currently access health data sets by approved researchers would have to apply to the Public Benefit Privacy Panel for Health and Social Care. They would assess your project. So you'd go with specific research questions with a research team. They would assess your project in terms of the risk to privacy and public benefit. If they establish that the public benefit outweighs the potential risk, then they approve your project. Researchers approved on the project would then access the data in a trusted research environment, which is generally the national safe haven in Scotland. So you go in and you log in to a secure environment to carry out any analysis. All your analysis is checked goes through disclosure control checks to make sure that it minimizes any risk of identifying individuals from the data set. It's also, I should say, the data set's pseudonymized before it's given to researchers. So we don't get names and addresses or anything like that. It's it's not even the actual CHI number. It's a anonymized version of that. So this is how you would go about accessing that data. But as I've said, nobody's used it yet. So I am very much hoping that that's what I can do as I sort of embark on an independent research program I'm at the beginning of now. So I thought I'll briefly just mention my research proposal. And I've done this at a very high level. I do have a more detailed slide if you're interested in specific bits of the research program, but I thought I'd give a high level overview of it. So as I've said at the beginning, I'm trained as an economist. So as you might have guessed, I'm interested in understanding costs, but not only monetary costs. Economists are generally interested in understanding how we can allocate finite resources, so finite social care resources, in a way that maximizes benefit or maximizes outcomes for the people using those services. So the first thing I want to do is characterize the current state of knowledge that we have on adult social care costs in Scotland, which are limited at the moment. There's really, the evidence is very sparse. I want to use that information and the social care data to evaluate the cost of social care, potentially across different disease types, but also trying to understand where there are differences across the country and potentially identify any inequalities in service provision and use. And this will really help me to identify potential policy relevant sort of target areas, which, given the backdrop of how the social care landscape is changing in Scotland, in terms of, well, the Scottish Government's recently announced plans to establish a national care service. This information on who is using social care services and where needs differ and where provision differs will be very important. And finally, and I've put this in a different color just to highlight, because I think that this is probably of most interest for this group, is really to understand the data opportunities for social care research. As I've said, nobody has used this data set yet for research purposes from an academic sort of point of view. And it's not clear. I have hopes that it will be able to do a lot, and it's better than anything that we have in the rest of the UK at the moment, but it's potentially still got a lot of problems. And one of the things may be, for example, on unpaid care. So we know that unpaid caregivers provide a huge proportion of care to older people and people living with complex disease. And it might be that this is not captured well within the source social care data set. So I think there's a lot of work to do to really understand what are the opportunities and what are the challenges of working with this data set in research. So the next steps for me, and a sort of points for discussion for us. So first things first, I need to get funding for this research. So I have a number of funding bodies that I'm planning to apply to within the next sort of 6 months. So I'm hopeful that I'll be successful in getting funding for that. I'm also planning on implementing a plan for public patient involvement in this work. And I wanted to put this up here just to say if anybody is interested in this work and wants to be involved in sort of from the outset in planning a proposal, in planning the proposal for these funding applications, then definitely let me know, because this is something that, you know, I'm very passionate about and want to make sure that I'm doing that from the outset. But in general, today I just wanted to use my data members' views on this work and just have a bit of a chat about it. And I think we're in quite a unique position and a good position here, that because social care data hasn't been used before, but healthcare data has, we can hopefully learn a lot from how things have gone with using healthcare data in research. So I think that it puts us in a very good position to make sure that we take away all the good practice that's been done in the past and learn from anything that has been poorly done within healthcare data research. So yeah, I thought maybe that would be a good point for us to have a sort of chat about, to make sure that anything that I'm doing with this data is ensuring sort of trust and transparency as we go forward with it. So that was all I was going to say. I hope I've not gone too far over time there, Chris. I think I waffled a little bit. But thank you very much for listening, and I'm more than happy to take any questions and yeah, have a chat.
Elizabeth, thanks. That was really good run through. No, you didn't run over time. That was me with the technology eating into your time at the start. Thank you for that. I think it's a really nice run through. It's really good to see the use of the citation as well, because that's an interesting use of that. That might be something we need to pick up and push. Just before I zip to Francesco's question, your point about is the data good enough to do this sort of stuff with is interesting, because if I go back probably 20 years, in the cancer community, there was some reluctance to use, in England, hospital data, because they'd already got cancer registration data, which they thought was better. So there's a fair amount of reluctance to do that. When the data began to be used by cancer and by other services, the hospital activity data, you have seen a significant increase in quality of that. And then more recently, the mental health data sets was often seen to be a bit incomplete, a bit inaccurate. Data quality was poor, but that began to be used more and more, and that's seen significant increases. So I would hope to see the same thing with social care data, in terms of if we use it more, we begin to push the need for quality, better complete data. So I
Yeah.
would encourage you to keep going on that one.
Yeah, no, absolutely. That's the sort of hope. Because I think as researchers, although it's not collected for research purposes, we might be able to, there might be very small changes that can be made in the collection that would make a huge difference to being able to answer some really important questions. So yeah, I'm hopeful that that's the case, and I completely agree with that sort of history of the other data sets that have been used.
Okay, Francesco, I've managed to bring you in, Francesco, by pressing a button, so I can see
Okay.
your hand, and you should be able to talk now. I'm not sure I can see your screen, but at least you're a real person to us now. Go
Oh,
on,
well,
off you go.
can you hear me? Yeah.
Yep,
I
loud
would
and clear.
thoroughly recommend for the future, stay well aware from webinars. They're always problematic with the other involvements that I'm involved with. Anyway, Elizabeth, thanks a lot. I guess given that we've still got Hadrian's Wall, what's left of it between us and England, you haven't got the Health Research Authority or Health and Care Research Wells. And I guess the difficulty in terms of things like Section 251, without having to get consent for people in, groupings in care. In England, I'm involved in research where they've applied to the Confidentiality Advisory Committee. And, you mentioned, one of the last things you mentioned about trust and transparency. So it would be good to ensure, but I think for those that you've kind of like invited to be involved with you, it's a whole new ball game, because the requirements in Scotland are totally different to that in England. So, people wouldn't necessarily be hitting the ground running. They'd have to come up to speed, and I guess distance. So the question is, really, if that's a fundamental difference, I just wonder whether or not you should be recruiting for people with lived experience of, loved ones that are in care home, residential home, with power of attorney, family carers, friends, and keep it local to, Scotland, because that's where the lived experience is. People in England can't talk about having lived experience of knowing what the system is like, being registered with a Scottish GP, etc., etc. And I know that the NIRHA, they want to, look at how you minimize underrepresentation and underserved community. So I guess you'd be far better off on your own manner. Question is, NIRHA, just by way of observation, for stage 1, if you're invited to stage 2, have got a very low success rate at stage 1. It's about 32% and just a bit higher at 40%. So I don't know how it works in Scotland. So I think the important thing is that, personally, in terms of what you consider, rather than having people in the room with you, what is the primary outcome and what is the secondary outcome, and how were they determined and by whom? Thank you. That's what I'd be asking.
Thank you very much for that, Francesco. I'll try and answer. I think absolutely take your point on board that there's a difference in the systems between England and Scotland, and so I'd absolutely be looking for patients and caregivers and things within the local community in Scotland who have more lived experience with this, definitely. But I think overall, in terms of using this type of data for research, I was interested in getting views of this group, where we don't have an equivalent in Scotland to sort of go to. So I think, yeah, leaving aside the sort of lived experience side of things, I think just wanting to know about what we can learn from the past and how that might apply to using social care data going forward. And sorry, the second part of your question about outcomes was yes. for this specific research.
Yeah. But basically, I appreciate that most of your work will involve extracting, I don't know, going on the equivalent of an NHS digital or its equivalent in Scotland, maybe looking at the grey matter, using a forensic librarian do systematic review, because ultimately, not too many public contributors have actually been involved in social care data. So what do they bring with them? And that's the difficulty. How will you use them as part of the, it's like having a PPI group for evidence synthesis. How do you use them for meta-analysis? How do you use them for systematic review? So I think you need, depending on how you get your information, that's something that, some of your team can actually extract by getting the permissions, as you do, as it is in England with IRAS and all the other bits and pieces. So it's a question of, how do you make use of patient public care involvement? Yeah, thank you.
Yeah, and I think that's something that I'll be exploring as I said, I'm at the very beginning of this program, so that's something we'll definitely be exploring throughout. We have the system in Scotland for accessing this data is the same. It's essentially similar to what happens in England, but in Scotland it goes through the same process as how we access healthcare data, and it's under the same sort of data protection kind of rules around consent, because it's not informed consent for using it, so it has to fit under the it generates public benefit sort of thing. So yeah, that's definitely something that I'm planning on trying to develop now as I'm at the beginning.
Well, I think just one last thing. Are you applying to the NIHR for the doctoral research fellowship?
I don't think that one's on my list.
Oh no, I was just going to say, because there's plenty of people that would be able to support you, whether it's a pre-doctoral, doctoral, or I don't know your background, or advanced doctoral research fellowship. So, you're far better off looking at your PPI group and forming them there. And if you do get funded, you've got the basis of your PPI group. Okay, thanks.
Exactly. Thank you.
Yeah, that's a good point. Now, I'm going to try and click a few buttons now to bring a few people in. Diana, I'm going to try and bring you in next because you put a question in chat. I can see your box on screen. You should be able to talk. I can't see your video. I'm not sure I can alter that.
No, it was a question related to Carers' Rights Week, which we happened to be in. It was Carers' Rights Day yesterday. And the aim this year is to recognise and support them, that is, carers in the community. And I was just wondering how your work, Elizabeth, might help this, or whether the lack of identification of carers, because there are many who are actually outside the social care system, how that would relate, how the two could get together. Would it be helpful, or would there be lots of gaps?
Yeah, thank you, Diana. Absolutely. And that's something that I think is very difficult because, as you say, even some caregivers themselves don't identify as caregivers. And that's always where there's quite a difficulty of getting this information. Whilst there is, I think the one thing I've found in the past when trying to understand unpaid care and paid care is that we quite often only see one side. So we see either from the caregiver's perspective or we see from the person who's receiving care, and we don't get them both together. So I think that this is probably where this data set will definitely fall down a bit. So it has an indicator in it which says, does this person also have an unpaid caregiver? And it's a yes or no. So that's all the information we get. But that information is recorded by social care workers who are providing this information. So there's, again, a lot of questions around how are they assessing whether or not the person has an unpaid caregiver. And I think absolutely it's probably going to highlight where there are gaps and that it's maybe not possible to get this. But I think that this data set's very unique in the way that actually it captures information on the person who's receiving formal care services and potentially some indication of whether or not they have unpaid care. And that's something that we don't ever get at a national level. It's usually only recorded in survey data that's primarily collected from participants, generally where the person is living with the person who's providing care for them. And again, this is all on the assumption that this person is identifying themselves as an unpaid caregiver. So it's very difficult.
May I follow that up, Chris? It was really the economic analysis that I was thinking about was more the follow-on, you might say, from whatever you find, the costs of providing what's missing.
Mm-hmm.
Because even if you're identified, there aren't always the funds or the resources, as you identified at the start, to fully support what's needed. I mean, years and years ago, I was involved in a nice thing about support for older carers, for people with multi conditions, you know, and I don't think that this has actually come about. I think there was still huge lack of care. I mean, you know, I know I'm talking in generalizations, but I'm trying to narrow this to a focus where within your research, you might be able to identify the areas of support that would be helpful to have more focus on and more funding for.
Yeah, no, and absolutely. And there is, I've not put up the full slide with the research programs, but a big part of that is on unpaid care, and exactly that, trying to identify, for example, if, you know, within dementia, we know that unpaid caregivers provide a huge proportion of care, and that there is a lack of understanding on the sort of intensity of that and the associated costs. So yeah, I think definitely this hopefully will be able to highlight those kinds of areas where there's further work needed. Another thing that we might be able to do at some point in the future, and again, this will only capture certain caregivers, but who qualify, but we the Scottish government now has devolved powers over the carers allowance, which has recently changed. It's not called the carers allowance anymore, it's called something else, but basically the benefit that's given to unpaid caregivers. So in theory, at some point it might be possible to be able to link that information in, so we'll know about if an unpaid caregiver was receiving that sort of benefit. But I think that would be further down the line. But absolutely, I think this is an area where there are a lot of unknowns, but we know that unpaid care is a huge proportion of overall care provision, and that it's essentially it's potentially very costly in terms of lost productivity and well-being, but also positive things as well. Do you know? So yeah, there's a lot of gaps there, but hopefully, as you say, we might be able to highlight some of those areas where funding might be better targeted for research.
Thank you.
Thanks, Anna. One thing that struck me, Elizabeth, when you were talking was I was just writing down some of my own questions. And one was, why is there so little work in this area? And is it because there is a lack of awareness in the research community about what data is and isn't available? Or is it just because the data just isn't there apart from small pockets? Is it to do with where to go for funding to do this sort of work? Or is there a problem with the process in being able to even access data when it does exist?
I think it's probably a bit of a mixture of those things. The access has definitely been a problem because it's been, so when I talked about that community health index number, which allows us to link data across between social care and healthcare, that didn't really exist for the social care data as it was collected by the Scottish government. So it wasn't being used in that way. Now that Public Health Scotland have taken over and it's been sort of moved, it's now held alongside those data sets. So it means there's less, you don't need the data sharing agreements that a researcher would need don't need to be between the Scottish government and Public Health Scotland and other sort of data controllers. So it's a much more sort of streamlined the way that data is being collected. But in honesty, I found that the expertise has just been focused on healthcare data, and I think in general as well, when we look at policy as well, social care has often been the kind of poor cousin of healthcare, and whilst healthcare funding has been ring-fenced, social care has seen a lot of cuts in funding, and it's just, there's just those kinds of differences on a sort of policy level as well. But I think that's definitely changing, and you can see, I think Francisco maybe mentioned one of the NIHR funding streams where social care has been is on the list of like priority research areas. So that is changing as well. Social care from an economics sort of point of view and research perspective, it's also been much harder to incorporate into economic kind of analysis. So often health economics research will take a health service perspective and ignore, these other sort of social care and also unpaid care kind of elements to it. But I think increasingly we can't keep doing that, because we know that it's just not possible. We shouldn't be thinking about these things in isolation. They're interacting. If somebody goes into hospital in an emergency and needs social care and they don't have a social care package, they end up staying in hospital for a long time, and it's often stressful for that person, detrimental to their well-being and for their families. So there's just, so much more that I think we need to be doing in this area.
Thank you. Just a reminder to people, if you want to ask a question, either just click the little raise hand button or put something in the chat, whichever's easier. I now have the technology to press a button and bring your box onto the screen so you can ask your own question, as Francesco and Dana did. Francesco, you got your hand up again.
But yeah, what I was going to say is, many years ago, with the London School of Economics and their other partner, University of Canterbury, I was part of an patient care involvement group with the Personal Social Services Research Unit. They're probably called something else now, but there was stuff going on. But some of it was, specific to putting a limit on the amount that individuals would have to pay towards their own social care, where it's not picked up on from the NHS and that. And I guess the difficulty is, since HRA have taken over the ethics and research application from the Social Care Institute for Excellence in 2015, it's been a lot slower. You know full well that if you go to any of the funding bodies, whether it's EME in England, it's EME, HTA and what have you, you want to do developmental grant, you know where you stand, you know where you're going with it. And most researchers tend to be from a health related background. So I'm just wondering whether or not, if there was like a similar, a national school for social care in the same way as we've got for primary care and others, whether or not, and with their own funding stream and putting out calls for researcher-led or commission-led, whether or not that would encourage more. But I'll tell you what, in terms of involvement with our local authorities in the Southwest, there's very little, and they tend to use some of the data that NHS England provide with the ASCOT data sets and that. So it's not something, although I'm involved in some research looking at, people in care homes and that's about the only time in about 13 years there's been an opportunity that people can access. I don't know where those adverts go to, or whether or not there is little or no patient public care involvement. Okay, thank you.
Thank you. Yeah, no, I think that's fair assessment. I'm not too familiar with the English side of things, but I think definitely, there's just not been as much focus. I think we saw that during COVID as well. There was obviously a huge media focus on care homes and things, quite rightly, at the time, but we didn't hear much about people who are receiving adult social care in the community, and in Scotland at least, and I think it's similar in England. We know that there's a far greater number of older people receive care in their own homes than they do in care homes, and we didn't know anything really about how they were being affected by COVID. And yeah, I sort of like going along to a lot of meetings saying, but we have this information, so we should be able to do something with it. But yeah. I think Victoria's got her hand. Yeah.
Victoria,
yes.
off you go.
Yes, I'm sort of in between all the categories you're speaking about, but I'm in England, not in Scotland. So I cannot participate from that point of view. But nevertheless, there are many questions that come to mind because there are patients who receive attendance allowance, and but they need some assistance with other things. And it's very difficult to categorize how they are managing. For example, you may have an equipment because of your condition, and putting it on and off, you need a personal carer. And there doesn't seem to be much recognition of the fact that if you cannot use those things effectively, it's impacting on the outcomes, so that they end up spending more because the person may then develop another condition in addition to what they're being cared for. I'm not sure if I'm making sense, but yes, I had some support socks that I found very challenging putting on and off, but I don't qualify for personal care in that sense. And your attendance allowance just sort of goes into things like the heavy work that it is realized you cannot do productively. So I'm interested, and I may get into discussion with you to see how things are going, and then see how one can do something for this end of the UK, because there's a big gap. And I said to myself, well, I've had all my medication and physio and this, but this thing has just, spoiled all the outcomes and making it more expensive. Anyway, I'll stop there.
Thank you, Victoria. No, thank you for sharing that. And I think definitely happy to have a further conversation and discussion. I think that definitely the work that we could do with this data in Scotland, whilst the systems have their differences, there are also a lot of similarities in the sort of populations and things that there might be a lot that we can learn, that the sort of findings from Scotland will be useful for the population in England, and specifically, maybe trying to pick out the sort of unique kind of groups that you're mentioning.
Thank you.
Thank you.
I noticed that Hayley's put something in the chat about the work the Health Foundation did on adult social care data during COVID.
Yeah, they were actually the only people that had some stuff on home care. They did a small piece, and maybe actually if there's something else that's more recent that I've missed. But yeah, so I was involved in a long-term care COVID report, which was mostly looking at deaths within care homes across the UK, and a worldwide report. And I was doing the section on home care to try and just bring that in, because it was all very much focused on care homes. And yeah, the Health Foundation work was one, I think, that I cited in there. I think what I was frustrated about at the time was that I knew that we had national data on we knew at least every single person, adult in the UK who was receiving care at home. We knew if it was personal care or if it was other sort of non-personal care services. And nobody was sort of looking at that at a national level. I'll look
Hayley,
back at the report, Hayley. That's thank you for mentioning that.
Yeah, I'll put you on screen, Hayley. You're not compelled to talk, but I just thought if you wanted to follow it up, you could say something now if you wanted to. It's not, don't worry.
This was my first sort of very first PPI thing that I ever did. And from a personal perspective, it was actually quite distressing to do. My mum died from COVID very early on, April 2020, having been in a care home. So actually, while it's distressing, it just shows how worthwhile PPI work can be, because the gaps, and I think they are now deliberate gaps in social care knowledge, it just shows the impact of not gathering the data, doesn't it? So yeah,
absolutely, yeah.
I know Jackie has just put something in the chat as well. Again, Jackie, you don't need to say anything if you don't want to. I'm just reading what you put in the chat. But Jackie's been working on projects about the cost of caring for carers.
Thank you, Jackie. Yeah.
Offering an introduction. So again, Jackie, I don't know whether you want to say a few words or not.
Right. No, Professor Claire Gardner, she's been doing work. She used to work at, I think she may well still do, work at St. Luke's Hospice in Sheffield. And myself and another group have worked with her for, well, years, 20 years, in fact. And this is her project, Cost of Caring for Carers, is every 6 months we do something. And that's because I think it's funded by the university. But she's very knowledgeable on this sort of thing. And if you want an introduction for a chat, I'm more than happy to do that. She's really nice to work with. And
thanks,
she's
Jackie.
Also got a good team. Sorry. The Palliative Care Advisory Group, she leads that, and we work on topics to do with that as well. And I suppose in your PPI team, you also want people, don't you, who are possibly looking at some sort of care in the future. In other words, you want the oldies.
She's talking about me.
Oh, I wouldn't say that, Chris. Anyway, that's an offer if you should want it. And
thanks, Jackie. No, I appreciate that, and definitely part. Although I didn't mention it too much in the talk here, part of the plan for the program is specifically looking at that unpaid care and trying to understand the cost of unpaid care. And I've done some work on that in the past. So definitely keen to know what else is going on in that area.
Right. Well, I'll send Chris a link then.
Thank you.
Okay.
Thanks, Jackie. I'll pass that through. And Diana's put an extra question about the IFS report. Diana, I think you're unmuted now. Did you want to say anything on that?
It wasn't so much a question as just trying to underpin my other question. I don't really want to hug all the time. I just was pointing out there was an IFS report, and I've given a link some years ago, because it said social care spending per adult varies considerably across the country, and only a quarter of the differences can be explained by observed indicators of local need. And then again, it explains it partly caused by the distribution of cuts to funding and planned additional funding. And this is where your economics might come in, I think, which is to be allocated on the basis of need, would go some way to matching spending with needs. And that's why I was asking, you know, how much granularity if there would be.
Yeah, no, I think that's a really helpful thing to raise, and this is definitely what I found during my PhD when I was trying to do that, to sort of match up need in the population versus provision of care or use of care, and found that they didn't actually marry up, and like the IFS report, there's huge variation across Scotland. That can be a lot to do with local funding, with eligibility criteria. So although in Scotland we have free personal care for everybody that's not means tested, then there are national criteria for eligibility. They are applied at a local level, and there can be differences. So depending on where you are, and that was something that kind of came out in the work that I did in the PhD. So it will be something that I'd hope to explore more with this more granular data. On funding, we can get a bit of information, but I plan to do a bit on looking at costs, like prices that local authorities pay for services, because we know that they also differ, and that might be part of the reason why there are differences in provision as well. But yeah, I have to choose a few things to work on. I'm like, there's so much we could do here.
I'm sure there is.
It's
Thanks.
a significant area. Yeah.
Thank you for putting
Danny.
that link in.
Yeah, I'm just conscious of time because we're now just run out of time. A couple of things to sum up. I think at some point we might think about, maybe we need a wider webinar about what data exists about social care, who's analysing it, and what does it show. That there might be something in there where we could do a bigger piece on that later on next year, maybe. One other question I got for you, Elizabeth, before we wrap up is it easy to find where data on social care actually exists? Or have you just found it by accident in Scotland?
So I think I was involved in this project when I started my PhD, that my supervisor was already kind of involved in. So I was sort of just pulled into it that way. In Scotland, it's not easy to find, partly because the Public Health Scotland website is very difficult to navigate, and I think they've moved from they used to be called Information Services Division Scotland, and they've transferred over. So there's a lot of historic pages that you find, but it's quite difficult to find it. I think it's the Professor Martin Knapp's group at the London School of Economics, the Centre for Care Policy Evaluation Centre. They have produced a summary of all social, or a list of social care data sets that exist in the UK very recently. It's a really helpful resource. So I can look out the link for that and send you it, because I was just thinking there that is somewhere where you can go and see. But actually, when I looked at it, the Scottish data is not on there. So I think I said to Martin, can you add this on, please? Because
well, if you've got that link, that'd be good, because we'll put a note in the newsletter when this recording's available for people, and we'll put something on the bottom of that to say, here's somewhere to look. My final question is it worth a question to the Health Data Alliance, which HDR UK, Health Data Research UK, set up? Because those members of the Health Data Alliance are basically the big data controlling bodies. And I wonder whether it's worth a question to them to say how many of them have social care data.
Yeah.
I'm asking that because they've asked us to join as members, so we can actually ask questions now.
Yeah.
So that
I'm
might be
not
something I
sure.
can take away.
I have I'm hoping to apply for a HDR UK fellowship, and I sort of mentioned to them that, you know, I'd be using social care data. Is that something that's been done already? And the answer is no. But I mean, it's health data research, but I was kind of like saying, but social care needs to be in here as well. So yeah, that's a question worth asking. But I think I definitely just say that there's no academic researcher that's gone through the process of accessing this data and linking it to healthcare data. So I'm about to start doing that. So I'm not sure if there might be unforeseen sort of obstacles that come up in terms of me actually getting access to this. So yeah, we'll have to wait and see. But in theory, there is no reason why it should not be possible.
I think that's a good place to stop. That's been a really helpful run through, Elizabeth. Thank you for your time. Thank you for all those people who dialed in and got stuck behind a black screen because I couldn't get you in. And thank you for those who asked the questions. We'll see if we can modify the format back to as we were last time, where we could all see each other and have a bit more of a chat. So thank you for your patience. Elizabeth, thanks ever so much. Have a good rest of the weekend, everybody. We'll send a note round when we've got the recording available. You can rewatch. We'll send it out to the other members as well. If anybody wants to get in touch with Elizabeth, either do it through me or through our Elizabeth, who sends the email out. We'll put people in touch. And,
yes, thank you.
yeah.
Thank you so much for having me.
Thanks,
Thanks, Elizabeth. Thank you, everybody. Take care.
Thank you.
We'll finish
Bye.
it off
Bye.
there. Thanks all. Bye.
Bye.